Today's presentation will be on postpartum depression. At the end of today's presentation, our learning objectives would be to recognize postpartum depression, identify a postpartum depression screening tool, describe how others view persons with postpartum depression and how they view themselves, and compare how persons with postpartum depression fit into different societies. We will also describe how postpartum depression impacts school, relationship, and work. First, let's define what postpartum depression is. According to the DSM-5, postpartum depression is citing an onset of depressive symptoms within 4 weeks of giving birth. Clinically, postpartum depression is often diagnosed when symptoms occur within 12 months of a child's birth. Postpartum depression is different than major depressive disorder, which is characterized by a possible combination of symptoms which include depressed mood, akathisia, change in weight or appetite, sleep disturbance, inappropriate guilt, psychomotor disturbance, fatigue, diminished concentration, or thoughts of death or suicide. The use of the term postpartum recognizes that depression associated with having a baby often begins during pregnancy. Many of the symptoms, sleep deprivation, weight changes, fatigue, may be experienced as part of routine infant care or secondarily from sleep deprivation related to infant care and do not constitute a depressive disorder on their own. Therefore, a detailed history is critical to differentiate between postpartum depression and a normal postpartum cause. Here we can see incidences that's been reported of postpartum depression. We should also keep in mind that according to the American Academy of Physicians Assistants, the true incidence of postpartum depressions may be higher. Let's discuss the difference between baby blues, postpartum depression, and postpartum psychosis. Up to 70% of all new mothers experience the baby blues. Baby blues are defined as a short-lasting condition that doesn't interfere with daily activities and doesn't require medical attention. Its onset is usually within 3 to 5 days of delivery and persists for a maximum of 1 to 2 weeks. Postpartum depression, in comparison, is emotionally and physically debilitating and may continue for months or more. The onset is usually within the first several weeks after delivery. Postpartum depression can persist for up to 1 year, and it's a serious medical condition. Getting treatment is important for both the mother and the child. Postpartum psychosis is characterized by the presence of delusions and/or hallucinations, paranoia, grandiose or bizarre delusions, or mood swings, confused thinking, and disorganized behavior. Its onset is usually within the first several weeks after delivery, and it's a serious condition. Patients are more likely to act on harmful thoughts, so safety is our most prevalent priority in postpartum psychosis. Risk factors. The most significant factors appear to be a history of a depressive episode or major depressive disorder and the occurrence of a stressful life event. Research has been inconclusive about low socioeconomic status being a risk factor. Screening and diagnosis. Antenatal and postnatal screening is recommended by multiple organizations, including the American Academy of Pediatrics, the Academy of Breastfeeding Medicine, and the American College of Obstetrics and Gynecology. There are multiple tools that exist to screen for postpartum depression. These instruments are useful for screening, but they should not be used alone to make the diagnosis of postpartum depression. A positive screen should prompt the clinician to conduct a complete interview to determine if the patient meets criteria for a major depressive disorder. One tool we use is the Edinburgh Postnatal Depression Scale. It's both sensitive and specific in detecting postpartum depression. Its easily readable self-report scale of a 10-question questionnaire which assesses a patient's mood over the past week. It asks respondents to choose from a closed set of possible responses which can be compared and scored in just a few moments. Each response is given a score of 0 to 3. A total score of greater than 12 or any positive response to the item "the thought of harming myself has occurred to me" should prompt a more complete assessment for depression. The threshold score is 12 to 13, which means those scoring above 13 might have postpartum depression. It can be accessed online and available in more than 35 different languages. It's commonly administered at the 6-week postpartum mother visit or at the 2-month well child checkup. In cultural groups where women are reluctant to disclose depressive symptoms, a lower cutoff may be appropriate, for example, the cutoff of 8 to 9. Treatment. First-line therapy is counseling, the use of medications, or both. Psychotherapy is used in women with mild to moderate symptoms. It's a better option for women who are breastfeeding and do not want medication. Cognitive behavioral therapy is where patients are encouraged to change their thought patterns and improve coping behaviors. Pharmacological options are also available. SSRIs, which include Prozac, Paxil, and Zoloft, may be used. Tricyclic antidepressants, such as Palmar and Torphanil, may also be used. After depression has resolved, women should be treated for an additional 6 to 9 months before tapering the medication in order to avoid a relapse. Culture is made up of shared ideas and perspectives. Cultural elements may ease the stress associated with new motherhood. The definition of roles, community support, and rituals are well defined, and therefore it reduces tension. Postpartum depression outcomes. Personal situational factors include the mother's characteristics and perception of herself. Postpartum factors represent the infant's impact on the situation, including health, sleep deprivation, and cultural activities. It also includes the incidence of partner violence and social support. Chinese, Indian, and Islamic societies place a higher value on male children, so gender preference is a risk for postpartum depression in these cultures. Postpartum depression outcomes can be broken down into 4 main components: mental health status, how is the mother coping with changes from birth, maternal role attainment. In some cultures, rituals define maternal role attainment, and the mother is less concerned or confused about this. Family health and well-being. It's tied to the amount of support the mother has to care for baby and household, and quality of life. Significantly impacts the mother and child. Quality of life includes the weight, length, illness, sleep, and motor cognition. Weight. Infants of depressed mothers gain less weight than infants of non-depressed mothers. The same is true for length. However, this effect did not persist over time. Illnesses. Maternal depressive symptoms at 5 months seem to predict more overall physical health concerns for infants at 9 months and a greater proportion of childhood illnesses. Sleep. Higher depressive symptoms were associated with an increased incidence of infant sleep disorders. Motor. Symptoms of maternal postpartum depression were associated with lower fine motor scores in infants at 9 to 18 months of age. Cognition. Maternal insensitivity associated with delays in children's cognitive development and has a negative impact on early child development. Mothers often feel detached from the infant. In postpartum depression, It may lead to decreased quality of the relationship between the mother and her partner, and the mother may be at higher risk for suicide. Postpartum depression mothers need careful screening, diagnostic, and treatments to promote wellness for mother and child. New fathers can also experience symptoms of postpartum depression. The symptoms may include fatigue and changes in eating or sleeping. An estimated 4% of fathers experience depression in the first year after their child's birth. The American postpartum experience is usually where the mother is discharged from the hospital in 2 to 4 days after an uncomplicated delivery, basically a vaginal delivery. They may or may not have help at home, and the partner usually returns to work soon after the birth of the baby. The mothers are then left alone to care for themselves, the baby, and recover from birth and to breastfeed. In other cultures, the postpartum period may be different from the American experience of postpartum. For example, in other cultures, there's a distinct postpartum period. For example, Korean mothers and newborns are secluded for 3 weeks. Chinese mothers do the month, which is staying secluded with the baby for 1 month, and it includes activity and diet restrictions. Japanese mothers go to their parental home in the third trimester and remain there until 4 to 6 weeks of postpartum recovery. Other cultures may have rites and rituals aimed at protecting the mother during the vulnerable recovery time. For example, Punjab mothers have ritual ceremonies of shampooing, bathing, and serving the new mother ceremonial foods. And in Somalia, the mother wear earrings made of garlic to deter the evil eye. Some cultures also have a mandated rest period, which often includes seclusion away from others. For example, Mexican and Hmong mothers practice a 30-day rest period. Eastern European women are secluded in birthhouses for 5 days after giving birth, emerging only to greet the father and extended family, followed by 1 month of social seclusion. Amish mothers have a designated rest period and an organized support system for social support. Ugandan mothers are secluded until 3 months postpartum. Physical assistance may also be offered to new mothers. Many of these cultures have extended families which take over running the household, caring for old children, and assisting with meals and meal prep. Social recognition of the new role is also important in different cultures. Somalian women have a celebration of the new mother and baby after 40 days postpartum. Nigerian women are celebrated after the appropriate rest period, and many cultures have celebrations that welcome the new mother and baby into society. These celebrations recognize and reward the new mother for her new status. How others view mothers with postpartum depression. The mothers are expected to stoically fulfill the motherhood role with grace and dignity, rather than asking for help. Mother is selfish or ungrateful for the healthy baby if the mother does not give the appearance of bliss in motherhood. The mother is shirking her responsibility towards motherhood and is scorned if she complains about the stress she is enduring. Mothers are often compared to others, which is not helpful. For example, when I had my child, the mother then blames herself for her depression. The mother is stuck in a harmful cycle, feels detached from the baby, feels angry the baby is waking them up again, and then feels guilty she's a bad mother. It then starts the cycle over. Mothers feel they must wait until their 6th week postpartum check-up to talk to the medical doctor about any issues. Usually at this time, mothers are too overwhelmed to look for community resources. OCD is a form of anxiety, and it also happens where the mother is obsessed over the health of the baby. Is the room too warm? Is the baby going to stop breathing? Is the room too cold? Is the baby dressed warm enough? Mothers feel ashamed to admit they would like some attention instead of the baby. Everyone keeps asking about the baby. No one cares the mother had major surgery. Women with postpartum depression often have a hard time describing their symptoms. Many don't realize they are suffering from clinical depression that requires medical assistance. Postpartum depression impacts school, relationships, and work. The mothers continue to feel guilty after postpartum symptoms subside due to remembering their actions. Sleep disturbances and anxiety leads to poor ability to attend to tasks and make it difficult to successfully return to work. Usually, the relationship with the partner suffers. Nursing and postpartum depression. Using screening tools is essential during pregnancy and the early postpartum period to help detect any postpartum depression symptoms. As a nurse, you must educate women on symptoms and to help them be aware of symptoms. You need to provide individually and culturally appropriate postpartum care. Nurses must also provide women with opportunities to discuss their transition to motherhood, facilitate access to support groups and other resources, and utilize telephone visits and screenings at well child visits to check for postpartum depression. In conclusion, nurses should be aware of their own cultural biases when caring for patients. Nurses should be sensitive to the culture of the patient. Nurses should be sensitive to the various symptoms of postpartum depression and recognize that women themselves have difficulty expressing need for help and are more likely to do so when approached in a culturally sensitive manner. These are my references that I used to put the presentation together. Um, if you guys need any more information, you could find information here, or of course we can use our friend Google, or we could utilize our professors. Thank you.